Hello, and welcome back to Child Mental Health for Pediatric Clinicians, helping you help kids. I'm your host, Dr. Elise Fallucco, child psychiatrist and mom. In our previous episode, we talked a lot about the science of stimulant tolerance with Dr. James Waxmonsky. And if you haven't listened to the previous episode, definitely go back and take a listen. But to recap, Dr. Waxmonsky is chair of child psychiatry at Penn State and co-PI or head PI for a number of NIMH-funded studies regarding treatment of kids with ADHD. But for today's episode, we're going to have Dr. Waxmonsky put back on his clinical hat and share with us 3 clinical pearls and strategies he uses when evaluating children and teens with ADHD. So let's continue our conversation with Dr. James Waxmonsky. So first, could you share with us some important things that we should keep in mind when assessing kids for ADHD?
Do your job to figure out if a child has ADHD and then get measures of symptom counts. That's fairly easy. The Vanderbilts are very good at that. But then figure out a goal. Why is it that the parent's here? What is it that the adolescent or even the adult is here for? And that's got to be in their own real world language. The goal is not symptom reduction. No one comes to you for a lower Vanderbilt score. And then your job as the clinician is to figure out, can you connect ADHD? And then again, the ability of meds to change ADHD symptoms to that goal and live in a pathway of that goal. Well, if your goal is to go from it's usually something like I'm failing and I need to pass. And so then the question naturally becomes, well, why are you failing? And it encourages you to dig through those details. Then you just have to, the knowledge piece is to know what the meds have a capacity to do and what they don't have to do. But if you don't start with a goal, we're always chasing symptoms and it looks like everything works because yes, the meds do reduce symptoms, but that's just not the relevant finish line many times.
Right. And that it's what's the meaningful outcome for the family and for the patient is not necessarily going from, 7 out of 8 symptoms to 3 out of 8 symptoms or decreasing the severity of each symptom if it's not resulting in changes in overall functioning or whatever they care about.
We have to remember these are stimulant meds. They create a sensation of alertness, and particularly amphetamine, they create a sense of what I'll call academic or cognitive confidence that doesn't really correlate with actual functional improvements. So relying on sensations of feeling medicated, sensations of feeling more alert, we do know there's very quick physiologic tolerance to that. That sensation fades, and if we chase that, that's when we get into weird regimens of 3 times a day extended release capsules or really high doses. But that doesn't really map on to functional improvement. And so I think it's absolutely critical to think about goals, functional measurable activities that you do either more efficiently, more accurately, or more of across the day instead of a general sense of focus.
You bring up a great point here that initially when we start a medication, we expect to see that patients feel subjectively more focused and more alert, and that can be a clue that this medication is going to be more helpful. But you remind us that this feeling doesn't necessarily last, and that doesn't mean that the medication is not working so much as our body develops some sort of physiologic tolerance to it. And ultimately, big picture, what we want to find out about is larger functional outcomes, whether that is grades or fewer behavior problems in class or fewer calls home from the teacher or whatever it is, that in parallel to asking the patient what their subjective experience is of being on the medication, we need to also be looking at bigger outcomes and more specifically family determined or family defined goals and outcomes.
I think the patient experience with this is critical. I think it's just our job not to take the first answer and interpret that as definitive proof of beneficial med effect.
So your first big clinical tip in evaluating a kid with ADHD is to get patients to define their goals. And I love how you worded this, for them to set relevant finish lines so that we as clinicians can figure out first if meds can help with this, and then if so, which medications can help meet their goal.
The second, we're pretty confident it's ADHD doesn't necessarily mean the meds are particularly effective at it. That we know there are things the meds are better at and things they're not so good at. They're not really good at making you more organized. So if your primary academic deficit is you lose track of things so you don't turn them in, I'm not really going to be real optimistic about the meds for that. If the main deficit is you rush through work and make careless errors, but you know how to do what you're doing, yeah, the meds are pretty good at letting you pace yourself better.
And I think it's easy to lump all of these things that are frustrations, either for the patient or for the teachers and the parents, and kind of lump them in one basket as this is ADHD. But I like how you're disentangling, like if the main issue is organization and potentially higher level executive functioning skills, like knowing when to do what assignment and how to pace. If you have a big science project coming up in a couple of weeks, that a medication is not going to teach you any of that or fix that necessarily.
I'm always very impressed by any colleague prescriber in primary care, because I know the average visit, you're going to get 7, 8, maybe if you're lucky, 15 minutes to taste this apart. I get 30, sometimes 45 minutes to do this, and it's challenging to do it. But, getting parents who come in who have that specific information as to what's behind the challenge, that really does help to focus the meds as much as we can.
Just tell me more about the biggest challenge. Is it more in the area of organization, executive functioning, planning, and prioritizing, or is it more in the area of physical, motoric hyperactivity, rushing through assignments, potentially impulsivity, blurting out answers in class, which the meds would be better at addressing? When you're taking a history from a family about ADHD, are there any specific questions that you like to ask that you found really give you helpful clinical information in a short period of time?
One of the most useful things I've ever figured out is we ask families when their biggest challenge of the day is. All day is an aspirational goal. We can't start with all day. If it's a big struggle in the morning, I don't know about Concerta. If it's a big struggle school day until 6 p.m., then that's a pretty good profile for it. But the drugs do differ when they on and offset. And that's one of the most useful things we can do for our families is give me your couple-hour window, which is your priority concern. We'll get to the other parts of the day. But it helps us to pick where we start, much more than anything else I've ever found useful.
Oh, fantastic clinical pearls that I want to emphasize and repeat that you just said. The first one is this question, a clinical question to ask when you're thinking about treating ADHD is ask the family, what time of day do they have the biggest challenge? And, getting ready early in the morning, great. We could get a short-acting methylphenidate or, potentially short-acting amphetamine salt product that'll get in their system fairly quickly to help in the mornings, or potentially do Jornay the night before. Whereas if the main issues are after a day of school, my child is bouncing around the halls, it's hard to do homework, it's hard to focus, we're all over the place, then a longer acting medication where you see a stronger effect later in the day, like Concerta, methylphenidate, Oros, would be a better option.
Yes, and I think just this sense of medicating the whole day is the ideal. I think that ignores tolerability. Medicate when the meds are clearly proven to be helpful. And because medicating the entire day is hard to do and does increase the challenge with side effects and maybe long-term tolerance. So simply because a med is helpful at one time of day, I don't think it's proof that it's helpful at another time of day. And it's really up to us as the prescribers to figure that out.
I think it's always important clinically to not take for granted that parents may not and families may not intuitively know that you're taking a medication and that it's not going to dramatically change you overnight, and it's not going to take away ADHD symptoms consistently over the next 24 hours and for eternity, that they are, that it's more complicated than that.
Yeah, I mean, particularly with the stimulant, because they all have very defined time frames. And then my last little tangent on this, and you'll have to rail me in, is I'm a big fan of generic meds, but a lot of these meds are release mechanisms. And unless the generics account for the release mechanisms, they're appreciably different meds because they're all just methylphenidate. Generic Concerta really you shouldn't use that word. It's generic ER methylphenidate that exists in the same doses that Concerta does. That mechanism is very specific to the Concerta brand and the patent, and it's not recreated in any other generic that has 18, 27, 36, 54. Some of the generics are designed to look like it is, but it isn't the same mechanism. So it's the one ADHD drug where we really don't consider the brand product to be equivalent to the generic. So if you want the length, the generic methylphenidates are kind of potluck.
So we want to be careful about prescribing generic Concerta and to make sure to prescribe brand if we really want and need true long-acting delayed release. Dr. Waxmonsky, you've already shared 2 helpful clinical questions to guide us in developing a treatment plan for kids with ADHD. The first is asking the family to define their goals for the issues that they want to improve. And then second, finding out which time of day is most problematic. Do you have any other clinical pearls to share with us that can help all of us assess the level of severity of ADHD and monitor response to treatment? And this is a little bit of a leading question, but I wanted you to tell us about how you think about drift time.
We know, for example, when we do these classroom studies, that the average middle school student who doesn't have ADHD can be on task can look on task, I'll say that, for 37 out of 45 minutes of a class. So we kind of know what the average drift time is. So what we try to do instead of have you felt more focused is, all right, when you're in math, how many of those 45 minutes are you actually on and productive? And, often you'll get answers like, well, 5. All right, so that's not good. But when they come in at saying 20, and now they can say, well, you know what, it's really much closer to 35 to 40 minutes or almost 90% of the class. That at least gives me a little bit more sense of precision and confidence that the med is doing something than if I just simply stopped at, do you feel focused? And it's far from foolproof, but it adds a little bit of precision.
Do you get a good response from kids when you're asking specifically about minutes? Like, out of 45 minutes or in a 50-minute class, how many minutes do you think you're on task? Are they able to say that pretty well?
If they're here because they want something to be better and it relates to academics, then yes. Now, obviously, I'm not asking a third grader. But when you have, insightful middle school and up, yes.
That's interesting. So we're adding to our list of clinical pearls and questions this question about, in a given class, let's say it's an hour, or 50 minutes, how many of those minutes are you paying attention? These are great tools and great questions to just throw into an ADHD, either eval or follow-up visit, to help anchor things and to provide more specific data.
Over the years, I've found that helpful. And the other thing, particularly for middle school and high school students, is when you're given a chance to do work on your own, how many minutes is assigned? What is your goal going in? Because if your goal is simply to socialize because you want a break, I am not going to expect a stimulant to change that goal. But if your goal is to actually walk out of there and get work done so you don't have homework, all right, well, how many of those 45 minutes did you actually do work? And most teens, I think, know that, whether they did 5 minutes, 20 minutes, or 40 minutes. And if that's their goal, then let's see if the med gets you closer to your goal. And if it doesn't really matter how focused you are. You're not getting closer to your goal. So why keep the med?
Right. Ooh, I like that. And I like also getting the patient to define, here's what I care about, or here's what I want to do. And also acknowledge that there are going to be some classes or some time of day where their goal is not going to be to pay attention. Their goal is going to be to reconnect with their friends.
Yeah, meds don't change your goals. Maybe parents can slightly change your goals. People change their own goals, but meds are facilitators to get more out of your effort to get closer to your goals.
And side note, it reminds me of why I think our field is so hard, and in some ways why it's hard to manage and sometimes treat mental health conditions. If we have an infection and you can give somebody an injection of antibiotics or like Rocephin or I don't know, something like that, it doesn't matter if the patient really desires for the infection to go away or not. The med's going to work regardless.
I agree. And it's just, I always feel a little bit lazy when I say, to the parent, it's just not something your adolescent's interested in. I can't medicate them. Now, we can talk about how you might, quote unquote, kind of leverage them into more health promoting behaviors or better grades or what all that. But without that, we're going to get nowhere. But let's try to do stuff to kind of help synchronize goals and come back and see me in a month trying to push a med now, because they're just not going to take it. Even if they tell you they're going to take it, it's not going to do anything because they have no desire for it to do what you want it to do, because that's just not their goal.
Ooh, I love this discussion. And I want to summarize for our listeners the 3 clinical pearls that you gave us for assessing and evaluating kids with ADHD. First one is to ask families, what is the biggest challenge of the day for them? And to tease apart whether is it more executive functioning, attention, hyperactivity, and impulsivity. And on a related note, to then get them to define functional goals or meaningful finish lines for what they would like to see improved or different. The second is to ask about the hardest time of day. And the third is to ask specific questions about drift time, meaning in a 45 or 50-minute class, how many of those minutes are you actually paying attention compared with how many is your attention drifting away or thinking about something else? And if you enjoyed this episode, please click like or subscribe or follow so that you continue to be notified about any future episodes. And if you want to join our newsletter or mailing list, just check us out on the web at psyched4peds and drop your email in. So you can join our group of friends and colleagues on child mental health for pediatric clinicians. And if you're driving and didn't write down that website, it's in all of our show notes for every episode. So just click there, share your info, and you can become part of our team. Thanks for listening. See you next time.